Today I'm going to give the first of 3 talks about heart disease, and this one is going to be about coronary heart disease. Now, the reason for doing this, of course, is that the heart is an absolutely essential and extraordinary organ. At one level, it's a simple pump, but it's a great deal more than that. Every day, it will pump around 100,000 times and will continue to do so until the day you die. And by doing that, it takes oxygen to your vital organs, helps remove waste, and is very responsive to increased needs. So it'll increase its rate of pumping, the energy with which it does it, if you need it, and then go back to its base rate when you don't. And it keeps your blood pressure and flow optimized for the organs of the body. So it's quite a really remarkable organ. The function of the heart was actually not known properly when this college was founded in 1597. And the first real advance after that time was in the 1620s when William Harvey demonstrated the circulation of the heart. That was a really extraordinary advance and has led to a lot subsequently. And the heart is really one of the most studied organs because of its importance and because treating heart disease has become a central part of medicine. Now, in very broad terms, and of course I'm giving a broad overview rather than the multiple detailed areas, in broad terms, there are 3 sets of things that can go wrong with the heart. The first of which is where the heart becomes short of oxygen, mainly, not exclusively, because the blood vessels that supply the heart itself start to get narrowed or blocked. And that's known as myocardial ischemia or coronary heart disease. That's the subject of today's talk. Now, 2 other things that happen, which will be the subject of 2 subsequent ones. The heart's rhythm, normally very reliable, can go too fast or too slowly, meaning that it works much less efficiently. And the third thing is that the structures of the heart, might be the muscles, might be the valves of the heart, are damaged for a variety of reasons. And those, broadly, are the majority of the things which cause problems with heart disease. But the one I'm going to concentrate on, and really the most important of those today, is myocardial ischemia, or coronary heart disease. Its biggest importance is that this is one of the main causes of people dying in the UK and in every country around the world. It's now the 2nd most common cause of people dying, dementia just slightly ahead of it in the UK, but globally it would be the main cause. And within that, heart attacks, myocardial infarctions, as they're known medically, are the principal reason. And if you see the slide I put up here, what it shows is that really quite a significantly greater number of deaths from this than the next most common cause. The top one is, as I say, dementia. And there has been, what we got in the dark colours is the most up-to-date data from the Office for National Statistics, and then in the lighter colour bar is the average over the last 5 years. So there's been a slight improvement over that time. But the fact remains it is a major cause of mortality. It is, however, better than it used to be. And if you look at this graph, and I've shown this before in a slightly different context, what you see is that back in the 1960s, heart and circulatory disease caused around half the deaths in the country. And it's gone down now very substantially to a still substantial around quarter of the deaths. And what the graph here shows is the age-standardized mortality rates over the period 1911 to 2011. In the dark solid lines, what we have is heart disease, peaking in the 50s and 60s and gradually decreasing, red for women, blue for men. In the dashed line is cancer, which is beginning to catch up with and overtake heart disease. And in the dotted line, infectious diseases, absolutely dominant over a century ago, and certainly when this college was founded, but much less important over the last century. Coming more up to date over the last few years, this is what has happened to heart disease in terms of mortality, coronary heart disease, per 100,000 people sit between 1969 and 2020, which is when these data run on to. And as you can see, in the dark bars at the top is the male rate. The one at the bottom is the female rate, and in the middle is the average for men and women. Two things really to follow on from this. The first of which is there has been a really remarkable reduction over that time in terms of mortality from coronary heart disease or ischemic heart disease. And the second thing is that this hasn't happened in a single jump. This is not a single breakthrough. This is a whole series of scientific advances which have happened incrementally, built on top of one another, 5% improvement, built on another 5% improvement over time, and then steadily rolled out. And the third thing just to note is that the difference between men and women, although there's still a significantly greater rate of heart disease deaths in men, has decreased. And some of this is explained by a number of factors, in particular actually changes in smoking. And if you look in people under 75, and these would be relatively young deaths in the modern era, you see a probably even more dramatic improvement, where the rates of people dying of heart attacks or myocardial ischemia are really very low compared to where they were historically. So what actually causes ischemic heart disease or coronary heart disease? Well, the main cause, it's not the only one, but by far the main one, is atherosclerosis. And this is a build-up of mainly fatty but also fibrous material in the arteries that supply the heart itself, the coronary arteries. And these fatty deposits start actually very early on in life. And then gradually build up over time. And initially, it makes relatively little difference. Functionally, the heart's got quite a bit of functional reserve. But you then get to the point where they've built up to a point there is a critical narrowing. And at that point, people can start to get symptoms. They get a bit short of breath. They can start to get pain in the chest, also known as angina. I'll come back to angina. And then, in some cases, the narrowing actually suddenly gets a lot smaller or blocks off completely, and this is what tends to cause a heart attack or myocardial infarction. And the usual mechanism, although there are others, is you get inflammation or rupture of this fatty material, and a clot forms over the top of that and then blocks the remaining artery. And this leads to a heart attack. And if an area of the heart is starved of oxygen, that area of the muscle will be strongly damaged in the territory of that blood vessel, and it may well die and cease to be functionally useful. So that is what a heart attack is. Fortunately, and this underlies a lot of the improvements we have seen and could see in the future, many of the things which lead to this happening are modifiable. We can do a lot to change them. So if you look at that extraordinary improvement in ischemic heart disease, three broad sets of things have contributed, and the first of those is primary prevention. Primary prevention is something which is done often by the state, but by society, where the state is simply the mechanism by which this happens, to reduce the risk for the whole population. Not asking whether you've individually got risk, just say, let's try and reduce the risk for absolutely everybody. And this, of course, is a very common disease. Then you've got secondary prevention, and that's on top of that, is where you say this individual person has either got early disease or they've got very specific risk factors or things that make a disease much more likely. And let's do something specifically for her or for him to reduce the risk of further problems in the future. And this will be a discussion between an individual person a patient, and their doctor, nurse, or other healthcare provider generally, to talk about the risks and benefits of various treatments that are preventive. This is secondary prevention. And the third thing is when someone has significant disease or has a heart attack or other major event, treating this so that the chances of dying or having long-term disability as a result of it is significantly reduced. So you've got primary prevention, secondary prevention, which is done for individuals, and treatment after events or for significant disease. And I'm going to go through each of those in turn because the improvement has to be understood as a combination of all of these. Now, for primary prevention of ischemic heart disease, this has several different components, all of which have an important action. If you put all of them together, the impact on heart disease can be very significant indeed. The first of which is, and I'll go through each of these in turn, reducing smoking and also second-hand smoke, passive smoking, where someone else is smoking and a particular person downwind of them or near them is exposed to that smoke, because cigarette smoke is extremely liable to speed up heart disease very substantially. The second is reductions in air pollution, which have been significantly underestimated, I think, in their importance. Then there's doing things which help to modify the diet in a way which people are still eating the foods they enjoy, but with less risk. And in particular, this involves reducing salt, because, as I'll come on to, salt raises blood pressure, and also some of the fats. You can have particular kinds of fats in foods. Very important that we make it easy for people to exercise at all points along their life course, because exercise is important. And finally, reducing the societal drivers of obesity. And I'll go through each of those in a bit more detail. Starting with smoking. Smoking leads to premature mortality, often very premature mortality and symptoms from heart disease. It does very many other things as well, as everyone in the audience will know. It causes lung cancer, many other cancers, chronic lung diseases. But it also, importantly, significantly increases the risk of heart disease, ischemic heart disease specifically. Smokers themselves are at very substantially increased risk to non-smokers, and if you're a passive smoker or second-hand smoker because someone else is smoking around you, that still has an appreciable additional risk. Now, this is important at an individual level. It's also actually, it helps explain some of the significant difference there is around the UK and indeed many other countries in terms of the rates of mortality from heart disease. There is a strong correlation between the areas of the country which have high smoking rates and the areas of the country which have high deaths from coronary heart disease. And you can see that in this map on the left. Darker colours are people who are smoking, and on the right, darker colours are people with ischemic heart disease. Now, this isn't the only reason for these differences geographically, but it is probably the easiest to address. And were there to be a massive reduction in smoking, it would significantly reduce some of the variation we see around the country. Improvements in heart disease can be very rapid when smoking reduces or stops. And I think we'll just give an example. The last really major bit of primary prevention against smoking was the ban on smoking in public places where you could be affecting everyone around you. Studies of this showed many advantages, but within the heart area, a significant reduction in heart disease at a population level occurred. And this was often really quite rapid. And what you can see on the right is a study that looked, in this case, specifically in Liverpool, but it could have been anywhere. The bar is where the ban on smoking in public places was. And what you can see is an almost immediate drop in the number of people who were admitted with coronary symptoms. So really you can have a very rapid effect. So there's a rapid reduction in risk when people stop smoking, and then a longer term reversion back to ordinary risk over many years. But at any point you stop smoking, it improves the outcome in terms of heart disease. Very important to stress that the model of the cigarette industry is to take people at the youngest age they are allowed by law and addict them using very, very aggressive marketing. Most people who smoke wish to stop. And therefore, the choice has been taken away from them by being deliberately addicted by very powerful, very profitable companies at an early stage of their lives. Fortunately, smoking rates are dropping in the UK for purposes of health, painfully slowly, but the good news is that the rates in younger people are actually probably dropping fastest. And rates of smoking in young people now, compared to when people of my generation were in their 20s or late teens, are much lower and are still dropping. Current generation are extremely sensible about this. The next big thing that society can do to reduce the risk of coronary heart disease, this very common fatal disease, is reductions in air pollution. People, I think, underestimate quite how important air pollution certainly was historically and still is to some extent now. Outdoor air pollution caused by factories, by vehicles, indoor air pollution as well. And for those who are interested in details in this, I wrote a report on this which was released just a month ago. Over the last several decades, most forms of air pollution have dropped very substantially. And I'd like this in what we've got is in the dotted black line on the right is where things were back in the 1970s. And what you can see is the proportionate reduction in multiple forms of air pollution. For heart disease, coronary heart disease, probably the most important of these is particulate matter, or so-called PM2.5, small particles. And these have been dropping for really quite a long period of time, although this has unfortunately flattened out a bit more recently. So this improvement in air pollution has certainly contributed to the very significant improvements we've seen, and there's still some way to go. And some of the things we're going to see, like the electrification of vehicles, some of the final reductions in many of the most polluting forms of industry, will lead to further reduction in risk. Making exercise easier and fun throughout the life course and building it into ordinary day or making it something which people look forward to is also really important. Exercise is one of the most protective things that can be done to reduce the risk of coronary artery disease, ischemic heart disease. It's also very good for many other conditions as well, but it's specifically in this situation. And starting in childhood, making exercise just the norm, things like the daily mile is used in very many schools, walking football in older age, but also making it easy for people to, for example, have active transport. We used to have, what we've got on the right is the distance travelled by bike in the UK. And if you went back to the 1940s and early 50s, huge numbers of miles or kilometres, as they now would be, were travelled by bicycle. Much lower now. That is something we easily could turn around. It would have an immediate and significant positive impact on health, including coronary heart disease. Changes into the diet, where they can allow people to eat the things they want to eat but reduce the risk, can have a very major positive impact. And I'm just going to highlight one in particular, which is reductions in salt. Salt increases, mainly because of the sodium in it, increases the blood pressure for potentially for everybody, but in reality, for the most sensitive to salt are older people. And in the UK, we've had a useful reduction of around 15% in salt over the last decade. And most of this has been from processed food. And I'd like to pay tribute to the many companies which have been involved in trying to do this. And they usually do it incrementally so people don't realize that the salt is gradually reducing as time goes by. But we definitely need to go significantly further. Some of the products on the market, thanks to far-sighted views by the companies involved, have gone down by 20 to 40% less salt than 10 years ago, but certainly there's a lot we could do to reduce the saltiness of processed and manufactured food. Now, I'm going to stress that because most of the salt in the UK diet is involuntary. The people eating it have no choice about it. They don't know it's there. They haven't added it into their plate. It wasn't their choice. And if you look on the right, what we've got is salt in processed foods, And that would include things like breads, for example, and that's up to 60-ish% of the salt in the diet. Salt that is a natural part of the product, and then the amount that people actually add to themselves. So the salt that people add themselves, in the sense the salt they choose to put in, is less than 20% of the salt they receive. So it's really the manufactured area that we have the biggest opportunity for change. But of course, if people put less salt into their food, that reduces their risks. And finally, in terms of the primary prevention things I want to talk about, this isn't an exhaustive list, is obesity. And in the context of obesity, in contrast to all the other things I've talked about so far, smoking, air pollution, salt, for example, where things have been improving, obesity has undoubtedly got worse. Obesity directly leads to cardiovascular mortality, so even if someone has no other issues, if someone's living with obesity, the chances of cardiovascular disease are much greater. That's one of the reasons that in medical terms we're very keen to reduce obesity. It does a number of other things, increases some cancers, for example. And it also increases the risk of diabetes, which itself leads to an increased risk of heart disease, coronary artery disease. So obesity is a real driver of coronary artery disease, and the problem we have here is people living with overweight and people living with obesity. The proportion of people in the population has steadily increased. And if you look on the graph there, what you can see is just the average weight has steadily shifted to the right, where right is heavier, towards people living with obesity. This is particularly depressing, as what we're seeing is areas of significant rising obesity, and these are much more common in areas of deprivation, and that's actually got worse over the last few years. So this is something we really do need to tackle fairly forcefully. So those are primary prevention, things we can do to all of society to reduce the risk of heart disease. Now we move on to secondary prevention, and this is where people will have treatment for particular conditions or risk factors or very early disease. And there are, I'm going to talk about 4, but I'm going to talk about 2 in detail. The first is to help at an individual level, someone who's smoking to quit, someone who's living with obesity to help them reduce weight, someone who's not doing exercise to increase exercise. So this is kind of targeted things, but things I've talked about already as risk factors. The second thing is to identify people who've got high blood pressure, hypertension, and treat those. The third is treating high cholesterol in people who've got that. And finally, which I'm not going to talk about, I've done a full Gresham lecture on that to people who are interested in it, is diagnosing and treating diabetes as early as possible. So let's start off with high blood pressure, hypertension. This is a major, common, and treatable risk factor for ischemic heart disease. Now, just to understand a bit about the numbers, when your heart is contracting, the force in the blood is going up, it's part of the way it pumps it, and you get a high blood pressure reading called a systolic blood pressure, and then when it relaxes, you get a lower blood pressure, and that's what's called the diastolic blood pressure, and all of us have got those 2 readings, systolic and diastolic. High blood pressure, hypertension, contributes to, doesn't cause all of, but contributes to about half of heart and circulatory disease. So it's a really substantial risk factor. And it's common, around 28% of the UK population. Now, 2 things to say which are, I think, critical on this. The first of which is there are multiple possible ways in which blood pressure can be reduced. So if something doesn't suit someone, we can move from one thing to another. And secondly, there are a lot of people who are living, and this is what these data on the right show, there are a lot of people in the UK living with hypertension who are not aware they have it and therefore are not on treatment. So it's not a matter of their choice, they're not even aware that this is a risk which could be managed down significantly. And this is a shame because blood pressure is actually very easy to measure. Now we have automated machines widely available, and it is, I think, important for everybody, but particular people once they reach sort of 40s and above, to know their numbers. Because we can measure blood pressure anywhere. One of these machines, cheap and robust, really pretty accurate. You can measure them at the doctor or with a nurse, but you can also measure them at home, buy them from local chemists, at work, shops. Measuring blood pressure, there are many, many places it's possible to do that. And then you'll know whether you've got a high systolic or diastolic blood pressure. And the readings that, generally speaking, tend to trigger treatment are either a high systolic blood pressure above 140 or a diastolic blood pressure of above 90, usually with repeated readings. Now, there are certain things you can do to reduce blood pressure which don't require drugs at all. They include reducing your salt intake, as we talked about before, reducing alcohol, because alcohol pushes blood pressure up. Exercise, the more you exercise in general, the lower your blood pressure, and losing weight, even a little, will help. So it's not, there are lifestyle things we can do to improve our blood pressures. But there are also very many drugs which can reduce blood pressure. And they work by different mechanisms. I'm going to go through several of them because they're very important drugs, and several of the people in the audience will be on them. Many of the people in the audience will be on them at some point in their lives. So it's worth understanding a bit about them. The point to make about this, though, is that whichever mechanism they use, by reducing the blood pressure, they reduce the risk of ischemic heart disease. Now, which is the best drug for you, for me, if we have hypertension, depends on many factors. It depends on age, depends on existing heart disease. Many drugs have particular additional benefits. It depends on ethnicity to some extent. It depends on side effects. Some drugs suit some people better than others. So if people go in, they're treated, and the side effects are problematic, another drug can be used. Common ones, these aren't exclusively all of them, common ones which I'm going to talk about in a bit more detail are ACE inhibitors, things called angiotensin 2 receptor blockers. They have a lot of similarities, I'll come on to that. Calcium channel blockers, thiazide diuretic drugs, and beta blockers. There are others, but those are really the main groups of drugs you'll get in the UK. And these may be used in different combinations. Most people we treat on one drug, but some people are treated on two or more. Now, I think it's worth going through the mechanisms of these. So for the next 5 slides, I'm going to go through the mechanisms of these individual drugs, just to get a feel for where they came from and how differently they act. But the final thing they do is reduce the blood pressure. The first are the ACE inhibitors. And for many people now, these will be the first-line drugs to be used. These work on something called the renin-angiotensin system, and this is the kidney notices when blood pressure drops, and it then activates a system, the renin-angiotensin system, which actually leads to the blood pressure being pushed up. So that's the kind of the underlying mechanism that it works on. It's a way in which the body controls blood pressure, but sometimes the set point is too high. And the first drugs that were found to work on this system to reduce blood pressure were shown to block this, and they in fact originally came from the Brazilian pit viper, this photograph on the right. Now, by multiple, and the reason this was important for the pit viper was by dropping the blood pressure catastrophically, which the drugs do not, it could lead to disabling its prey. This led by many steps to the drug, the first of the widely available ACE inhibitors, a drug called captopril. But this was the first of many others that people may well have come across in the UK, enalapril, lisinopril. There are several others. Just a comment on drug naming, incidentally. Rather like all of us, drugs have a surname which actually tells you the family they come from, and a kind of first name that tells you it's them. So the prils are all, generally speaking, ACE inhibitors. So the ACE inhibitors work by preventing an enzyme producing angiotensin 2, which is a signal drug, and this leads to narrowing, angiotensin 2 leads to narrowing of the blood vessels and therefore forces the heart to work harder and the blood pressure to go up. That's the way it normally acts. So by blocking that, you get the reverse. You get relaxation of the arteries and veins, and therefore the blood pressure drops and the heart has less strain on it. As with all drugs, and there's no drug without side effects, there are side effects to this drug. Probably the most common one that's the reason for people to stopping it, and it sounds trivial until you've got it, but it's a very important one, is cough. And people can get a very annoying cough, which means it needs to be stopped and another drug is used. It reverses when people stop the drug. Because this is both a very effective mechanism to address the angiotensin receptors, but also the side effects from the ACE inhibitors that I've just talked about, another class of drugs working on exactly the same system has been produced. And these are the angiotensin receptor blockers, also known as angiotensin 2 receptor antagonists. So they work very much like the ACE inhibitors. In practical terms, they can be almost used interchangeably. But instead of the mechanism acting on the enzyme, what they do is they actually block the receptors. And there are a variety of drugs, again, which you can have. Losartan, for example, is one of the ones that may be widely used. They all tend to have this tan at the end. This class of drugs has very different side effects and doesn't, in particular, have the cough problem. That can be a reason people want to stop taking ACE inhibitors. Working by a completely different mechanism are calcium channel blockers. The body uses calcium to signal to large numbers of cells in large numbers of environments, including muscle cells. And some of the calcium channels, when they open, are going to signal to blood vessels that they should constrict and initiate that constriction. So the drugs that work as calcium channel blockers aim specifically to block these particular calcium channels. There are many types in the body, but these particular ones. And examples of drugs that do this are things like nifedipine. And the principal action, therefore, is to stop the constriction and therefore lead to a relaxation of blood vessels and so reduce blood pressure. They also can reduce spasm of coronary arteries, so this can be useful for symptoms in some people. And they do have side effects, including, for example, fluid retention. A completely different mechanism, again, are the thiazide diuretics. And these work in the kidney, and they mainly work by reducing reabsorption of sodium, which is being reabsorbed by the kidney the whole time to hang on to it. And this reduces the sodium and the total water, and this is the principal mechanism, it's thought, by which these reduce blood pressure. But they also may dilute blood vessels to some extent. So these are diuretics. And the final antihypertensive I want to talk about, and all of these drugs are important for other uses as well, are beta blockers. These were discovered and developed back in the 1960s. Sir James Black, photographed here, was one of the leading pioneers in this area. And this started from the understanding that adrenaline is used by the body as part of the flight and fight mechanism, and it leads to the heart going faster and blood vessels constricting. It's basically getting the body ready for action. So adrenaline stimulates, and these are the important bits for this particular drug, it has other actions as well. It stimulates beta receptors and on several organs, and the beta blockers block this and stop the adrenaline having the actions of making the blood pressure go up and the heart pump more rapidly. And again, many of these drugs have wide uses in medicine, including for reducing blood pressure. Examples include atenolol or bisoprolol, so lol ending for most of these drugs. So those are examples of multiple types of antihypertensive, and which one is best for someone, as I said at the beginning, varies. The next big risk which can be dealt with by drugs is reducing cholesterol. High cholesterol, specifically high LDL cholesterol, is associated with coronary heart disease and is part of that build-up of plaque in the blood vessels, which causes coronary heart disease. LDL tends to rise with age, and of course, the risk of coronary heart disease also rises with age. The drugs statins have really given us an extremely powerful tool to reduce cholesterol, and there is clear evidence of benefit, particularly for people who've previously had a ischemic heart disease problem, but also for people who haven't, but who've got raised cholesterol. It might be a family genetic reason, but has got raised cholesterol. And what I've shown you won't see the details of this. The point I'm making on the right is multiple different subgroups have been looked at in big studies. In this case, a meta-analysis of over 186,000 patients, randomized to statins or not, and they demonstrated all ages and with multiple outcomes, including coronary heart disease, there are improvements. So reducing cholesterol in those who've got raised cholesterol can be highly effective. Various drugs can reduce LDL cholesterol. The most important group are the statins, and they're currently first-line treatment. And drugs such as atorvastatin inhibit an enzyme, and this plays a central role in producing cholesterol in the liver. But there are other drugs that are coming along and are now in deployment, and they work by a completely different mechanism, and there are several drugs which inhibit by a variety of different mechanisms, something called PCSK9, and an example of this is the drug inclisiran, and these increase the liver's ability to reduce cholesterol, essentially. Currently, these drugs are used only where statins either can't be tolerated, and statins are usually very well tolerated by the great majority of people, or where there are other reasons that they may be needed as additional treatment. So you've got primary prevention, the secondary prevention, particularly antihypertensives, reducing cholesterol, and targeted action to help with things like smoking and losing weight. But even with optimal prevention, many people will go on to have cardiac events, although significantly fewer than without. And I think, as probably most people know, but it's worth remembering, a very severe pain in the chest is one of the things that should make people think about, have they got a coronary event, which could include a heart attack and many other possible causes. And heart attacks in particular, or myocardial infarction, is where, as I said at the beginning, the coronary artery gets blocked, and therefore there is insufficient oxygen to the muscle that artery supplies, and you get pain and damage and eventually death of the cells which that artery supplies. Now, in terms of the symptoms people get from heart disease, there are several, and there are three broad conditions I think it's worth talking about. The first is angina, then unstable angina, and then the most serious of these, myocardial infarction or heart attack. So angina, which is the narrowing of the blood vessel, but that is stable, occurs generally on exercise or other things that stress the heart. It's typically chest pain, but they may have jaw pain, they may have arm pain, and they may have shortness of breath. There are other things that can happen with it. But the thing about stable angina is that it is predictable. So someone will find that they get angina, for example, they get their chest pain if they walk up 2 flights of stairs. And if they rest, then the angina goes away. And if they walk up another 2 flights of stairs, back it comes. Unstable angina and myocardial infarction, heart attack, are a similar type of pain. Other symptoms I'll come on to, but these occur or continue at rest. So maybe someone started with a typical angina as they walked up the stairs, but then just the pain doesn't go away. This is a medical emergency. And a sudden shortness of breath, clamminess, dizziness, or nausea, even in the absence of chest pain, can be possible symptoms. Not everybody who has a heart attack has pain, although the great majority do. Now, there are many possible causes of of chest pain, and myocardial infarction, heart attack, is only one of them. But the things which people would be thinking about when assessing, if a paramedic, if a nurse, if a doctor is assessing, first thing are the symptoms and the history, what brought it on, including age. So the same kind of chest pain in someone who's 30 has a very different probability, much lower probability of being a heart attack, for example, than someone who's in their 70s. So the symptoms and history. The next thing is the heart tracing. And there are certain changes on the heart, particularly what's called ST elevation, where after the little beat, the QRS complex, the baseline goes up above where it normally should be, which signify a significant heart attack. And finally, and importantly, blood tests. These have changed over time, but now in the UK and most places globally, the key blood test is something called troponin. And if those are raised, they demonstrate usually damage to the heart. So if someone comes in with possible heart attack symptoms, there are broadly three possibilities. The first one is that this isn't from the heart. Now, some of the things which feel really bad in terms of pains in the chest are not dangerous at all, very unpleasant, but not dangerous. They're not from the heart, and they don't have any particular long-term implications, for example, spasming of chest wall muscles. Some things may be dangerous but are not heart attacks. Something like a clot in the lung can cause pain in the chest. So there are serious things that aren't heart attacks which are also need treatment. But in any case, these are not myocardial infarction. The second possibility, which is the other extreme in a sense, is when the paramedic, the nurse, the doctor does an ECG, and what they see is this ST elevation. And what you can see in the right is the normal little bumpy wave, the QRS, and then there's a flat area, and then the T wave, which follows that. In a ST elevation, that area is raised. And this indicates that someone has had a significant heart attack called an ST elevation myocardial infarction, shortened to STEMI. And these are likely to need urgent, i.e. emergency, interventions, including physical ones like catheterization. Third possibility is you may get the typical symptoms, and there may be some changes in the ECG, or there may not be, but what you don't have is the ST elevation. And in general, if there's a significant change to the troponin blood test, this is thought to be what's called an NSTEMI, a non-ST elevation myocardial infarction. It's a heart attack, but a smaller one in general. And if it's not, if it's very typical, but they don't have the blood changes, it tends to be called unstable angina. So the heart muscle hasn't died or been seriously damaged, but there's no doubt that there's a very, very near miss. I'm putting those together because although they are different, they are treated broadly the same. So those are the three broad outcomes. Not from the heart, STEMI, ST elevation myocardial infarction, or NSTEMI, or unstable angina. Fortunately, the treatment of heart attack has substantially improved over the last few decades. In the 1960s, it's estimated that around 7 in 10 people died of myocardial infarction. Now, 7 in 10 people survive. And if people get to hospital, the outlook for most people with myocardial infarction is actually now very good. And this has been achieved by a series of scientific advances, each one of which has lowered the chance that someone who has a myocardial infarction will go on to die from it. And I'm just going to highlight one because it's a particularly spectacular example of a very important trial that has changed practice in this area. This is a trial from 1988, so it's a while ago, and it was done in about 17,000 patients. This is a big trial done in people with heart attack, which are with ST elevation MI in the main, not absolutely exclusively. And the first thing they found was, at that stage, routine care was associated with 13% mortality. So 13% of people would die who had a heart attack. And by this stage, several things were already being done. Blood thinners, beta blockers, a variety of other things were already being used. So things had improved already. If people were randomized to aspirin, just one aspirin tablet, and then aspirin to follow up, mortality dropped by 20%. And then if they were given a clot-busting drug, and the one that was then used at that stage was something called streptokinase, which broke up clots, mortality was also reduced by 20%. And if you put those two drugs together, the mortality rate from a heart attack dropped by 40%. So this one trial demonstrated that two drugs could lead to a reduction of 40% mortality. And improvements have continued since then, but this was a particularly important milestone. And 30-day mortality is now less than 5% and can be down to 2%. So this is a really major change. Of course, some people sadly die at home before or on the way to hospital and don't get as far as the hospital. Now, worth pausing on the two drugs that I've just talked about because they are important. The first is one that almost everybody will have in their medicine cabinet, aspirin. And this was really the first drug that was also found to have activity against platelets. Platelets are bits of the blood which are involved in clotting. And so by using a drug which reduced platelet activity, the risk of clotting was significantly reduced. Now, this is a very old drug. Willow bark, which is where this originally came from, was used for fever, and aspirin does work against fever, from at least the time of Hippocrates. So that's about 400 BC. So this is a very old drug. It was promoted for fevers in the UK in the 1760s, and by stages got to the point where it was commercialized, and the Bayer company took it on initially from about 1897 and called it aspirin. Used a lot against pain and also against fever. The first trial to start for heart disease started in 1971, and I think people were really astonished by the fact that a drug that was so widely used and had been in everyone's grandparents' medicine cabinets, just not their own, was turned out to have such remarkable improvements in heart disease mortality. So several other drugs have subsequently come along which also help to reduce platelet activity. And now if someone has a heart attack, they will generally be given two antiplatelet drugs, aspirin and one of these ones. So a drug, for example, like called clopidogrel is quite often used in people who've had a heart attack or about to have cardiac procedures of various sorts. And they're usually given with aspirin, and in the long run, people will often continue on aspirin indefinitely. But they're mainly working against these tiny dots you see on the blood film on the right, which are platelets. So thrombolytic clot-busting drugs are the next drug I just wanted to talk about. It was the other one in that ISIS trial I talked about. The first was streptokinase. This is actually produced naturally by bacteria, particularly the beta hemolytic streptococcus. It was isolated in the 1930s, and the bacteria probably does it to break down clots so that it can move around the body and not be trapped by clots. was isolated, used for breaking down clots medically, and then subsequently some new drug classes, the TPA drugs, usually abbreviated as, have been used. But what all of them do is they break down recently formed clots. And I've illustrated this on the right just because I think it just shows the point. On the left, what you've got is at the hand of someone where one of their arteries has clotted off, and then they're given one of these drugs, and then you can see on the right the same X-ray of the blood flow through the hand has completely gone back to normal. So they can break down these clots and lead to the blood flow going back to what happened before the clot was formed. But what has been the next stage of development is that for most people who have an ST raise, a severe myocardial infarction or heart attack, a STEMI, will now be, if they're within a relatively short period of the symptoms starting, move straight on to have an angiogram, which is where they put some dye in and look at the blood vessels of the heart, and then if there's a narrowing that they can increase, or if there's a blood clot that they can remove, there will be direct action to widen the arteries immediately and therefore relieve the oxygenation of the heart. And what happens is people put in a sort of small probe that's got a balloon in it and around it a mesh, and then when it's gone through the narrowing, that is expanded and the mesh increases, and then the balloon is collapsed again, removed, and the mesh is left holding the blood vessel open. And this is used both in emergencies and, as I'll come on to, in people treating symptoms of angina. But in terms of improvement in heart outcomes, this has been another very major step forward in terms of our management of heart attacks. Now, this procedure has been around for a while, but it's been steadily improving in its quality over time. A whole series of different improvements have occurred. Two I'd particularly like to identify: drug-eluting stents, ones that actually produce drugs that make it less likely there'll be clotting around that network, and biodegradable stents, where some of them may actually just disappear over time. But the improvements are occurring, as I say, the whole time. Now, how rapidly you want someone, we would want to go to stenting depends on the situation. If a patient has an ST elevation, myocardial infarction, a STEMI, they will usually, if it's recent onset, go directly to having angiogram to see if something can be done directly. And if that can't be done rapidly, they will probably have a clot-busting drug, as I've previously described. If they have an N-STEMI or an unstable angina, they'll often quite rapidly, over days to weeks, go for angiogram and, if necessary, procedures. But that may not be immediate. In fact, it usually is not immediate, at least in the UK. And then if someone's just got stable angina, where, as I say, if they walk a particular distance or go up a certain number of stairs, they get the symptoms, they'll often be investigated with an angiogram and may have stents, but these are done as more of an elective procedure, so not as an emergency. There has been an increasing move to make sure that people who don't need to have a coronary artery procedure don't have one. And most widely thing that's used at the moment is coronary or cardiac CT. And this is essentially almost entirely, not completely entirely, non-invasive approach to looking at narrowing of the coronary artery. And if it's normal, people then don't need to go on to have a puncture in either their wrist or groin and a procedure where something dye is squirted into their heart. So it's a way of screening people out, essentially, who have typical symptoms. But if they have significant problems seen on that, or if that's not available or not appropriate, then they'll go directly to PCI to the angiography and angioplasty, where we put in a balloon if they have appropriate blood vessels. It very much depends on the individual and their own set of problems. The other thing which can be done so angioplasty is a way of going through the narrowing and then putting a stent in so that the blood vessel continues. An alternative way of doing this is coronary artery bypass grafting, and this can be taking one of the arteries, for example, the internal mammary artery, that from another bit of the system, plugging it into the heart, or it may in some cases involve taking veins and providing a bridge around a particular narrowing of the blood vessels. Coronary artery bypass grafting remains an extremely effective and important operation, but it's a major operation. Usually people will spend it involves splitting the chest open in most cases, although there are newer techniques, certainly may mean time in intensive care and quite a period of time to recover. So it's highly effective, but not without risk. And therefore, the choice between angioplasty, doing things within the arteries, and the surgery has to be done on a case-by-case basis. And if someone's got relevant things, the cardiologists and the surgeons will come and talk to them about which they think is most appropriate. But over time, and this is just UK data, on the top line, what we've got is the number of people who are having the angioplasty, PCI, and on the bottom, what we've got is the number of people having a coronary artery bypass operation. And as you can see, they're still used, but many more people will have this relatively straightforward and quick procedure. Often people can go home, if they're having it electively, the same day or the next day, compared to this major operation. And then in those who've had any kind of cardiovascular event, whether it's angina or a heart attack, they'll generally be put on several drugs. They'll be put on antihypertensives if they're not already on them, and we've talked about those already. They'll be given drugs to reduce their cholesterol, particularly statins. They'll be given one of the drugs or two of the drugs acting, or more, acting on the neurohormonal system, and things like beta blockers and ACE inhibitors, which I've, again, talked about already. And they'll usually be given an antiplatelet drug, aspirin, or others. And they'll have this group of drugs, and it seems a lot of drugs, but all of them have really clear evidence of benefit and additive benefit, so the combination is better than any one of the drugs alone, and that significantly reduces the risk of them having another major event subsequently. I'm just going to talk about one more drug class, and that's because quite a lot of people, again, will be on them now or will know people on them, and that's a drug class called nitrates. This is an old drug. It was originally noticed that people who were handling nitroglycerin explosives had symptoms, and this has been known since the mid-1800s, and it was recognized as a treatment for angina from the 1870s, at the end of the 1870s. What they do, the nitrates do, is they can be given by a variety of mechanisms. The most common ones are either a spray or a tiny tablet under the tongue for very rapid relief. So if someone's got angina, they can give them a prevention by a drug by mouth, which is gradually released over a period of time, or they've been given as a patch. Those are the most common ones. There are other ways of giving them. Those are the most common. And what they do is they relax the coronary arteries and indeed other arteries. Now they don't, unlike the other drugs I've talked about, they don't change the long-term outlook, but what they do is reduce symptoms. So they're very important drugs as part of symptom relief. Two other points before I summarize what we've talked about. The first is most people with angina, or a very high proportion of people with angina, have it due to narrowing of the blood vessels of the heart. And those will be seen on angiography or on CT or on MRI. However, it is possible for people to have angina, which is still ischemic heart disease, but with normal coronary arteries. And there are a variety of reasons for this, but two in particular just worth highlighting are people who have coronary artery spasm. So the artery is normal, but it spasms, and this causes ischemia. And the second is microvascular angina, where it's not in the big vessels, the big coronary arteries, but in the much smaller vessels. And the treatment for those is different than if you had a particular narrowing in one of the coronary arteries. So I'm making that point just because some people who have angina have to have slightly different treatments than some of the ones I've just been talking about, or for slightly different reasons. The second thing I thought it was worth highlighting it was inflammatory conditions. We've known for a long time that increasing inflammation increases the risk of cardiovascular disease. It does this in at least two broad ways. People who have inflammation, it probably accelerates the build-up of atherosclerosis and the development of cardiovascular disease. For example, air pollution, this is one of the ways in which it is thought, in fact, to have its activity. And secondly, if people have an acute inflammatory event, which should include several different medical conditions, but probably most commonly infections, this increases the risk that people will have an ischemic heart acute event, such as unstable angina or myocardial infarction. We've known this for many years. Many infections can cause this. The more severe the infection, the bigger the chance that someone will have a subsequent heart attack, and the longer the period of time, which may go out for weeks or months, that they are at increased risk. So a very severe pneumonia, for example, in intensive care has a much higher risk than someone who just has mild pneumonia, and that has higher risk than someone who has relatively minor symptoms. And the most recent of those, of course, is COVID, where after severe COVID, we know that there is a significantly increased risk of myocardial infarction, and for slightly less severe but still significant COVID, a lower risk but still a risk nonetheless. So inflammation and heart disease go quite strongly together. And then finally, I'd like to just conclude by tying together the various points I've made. We've really seen remarkable improvements over the last many decades in ischemic heart disease, coronary heart disease. And these have been a whole series of incremental improvements in primary prevention, in secondary prevention, and in treatment. In primary prevention, these have included reductions in smoking, reductions in air pollution, in some cases systematic improvements in exercise, improvements in terms of diet, particularly reductions in salt. In secondary prevention, we've now got a very wide range of things we can do to reduce people's blood pressure if they have hypertension. The key thing is to identify it and to reduce cholesterol, for example, statins. And then treatment of acute events, particularly heart attacks, myocardial infarction, have really substantially improved, where the chance that someone, if they call 999 and get healthcare rapidly, can reduce their risk of dying or having long-term problems as a result, have really substantially improved through combinations of drugs and emergency stenting and, for the right people, surgery when that is needed. So many things have come together to improve this. Many of those improvements will continue. For example, the continuing reduction in smoking is a major positive thing, but there are some headwinds, and probably the most important of those is the steadily rising obesity, where people are living with obesity and living with overweight because of the environments that they live in. So there's a lot in the future to look forward to. Drugs will improve, procedures will improve, but I think we should acknowledge that there are also some things that we need to do to tackle these other risk factors, which are going to lead to significant numbers of people having preventable heart disease. Thank you very much.